Today I'm going to talk about the patients with acute onset dizziness and posterior circulation stroke. We're going to go through the introduction. Why is this important? Why do we care about this diagnosis? Going to go a little bit back to basics, talk about pathophysiology and some anatomy. I'll try my best to keep it, only what you need to know because it's pretty complicated. Go through history and physical exam, what we need to look at for these patients, and then a timing and triggers approach to looking at a differential diagnosis, what the emergency room and OBS and inpatient workup should include. And then I'm going to give an overview of the acute onset dizziness clinical pathway that will be rolled out at the end of this month. All right, so as I go through this, I like to think of everything in actual patient cases. So the first case to think about is a 65-year-old male who has a history of hypertension, hyperlipidemia, diabetes, history of a stroke with some mild left residual weakness, coming in with 2 days of dizziness and lightheadedness. He hasn't really been able to take his medications or eat or drink anything because he's just been really nauseous and vomiting. So think about, what are you going to ask the patient? What are you going to look for during physical exam? What workup do you want to do, and what's your disposition? And then if the patient ends up in RE2 or admitted, then what other workup will you need to do for that patient, if any? And the second case is a 42-year-old male who's coming in. He has a history of hypertension, who's coming in with dizziness that started when he rolled over in the morning after waking up. Right now, he's sitting in the stretcher, he's comfortable, he's asymptomatic, but the symptoms return when he moves his head. And think of those same questions as I posed for the other patient. All right, so why do we need to learn about the acutely dizzy patient? The reason is because 3 to 4% of all patients that come into the emergency room are complaining of something in the dizzy spectrum. So they'll say dizzy, or they'll say the room's spinning, or they're lightheaded, or complain of imbalance. It's about 4.5 million patients a year presenting to emergency departments with this complaint. It costs about $10 billion. Half of those are going to have a general medical condition. So you have to think as a full picture, is there something serious that's causing this dizziness that's not vertigo or a posterior circulation stroke? But 3 to 5% of those that are coming in with this complaint will have a stroke. So that's why we're talking about it today, because this is a diagnosis. It's really difficult to make the diagnosis of a posterior circulation stroke if you are not thinking about it, and if you're not treating every patient that presents with this complaint in a very succinct way. So I'm going to tell you a good way to go and look at all of these patients from the beginning. So I'm not going to go through our pathway in detail, just want to give you an idea of what it looks like. And this pathway was developed in response to a couple of cases where we've had a delayed or misdiagnosis of posterior circulation stroke. So let's go back to basics. There is a fantastic YouTube video that goes over the pathophysiology. There is going to be a link to it on the ABP website. So go ahead and go there. I'm not going to go into this in detail, but just a reminder as to how our body controls our balance. So when you are imbalanced, there's a mismatch between your sensory inputs. You've got the visual center, your proprioception, and then your vestibular system, which is very important in this process. There are all sorts of parts of the brain that are involved. I'm not going to go into detail, but you have your vestibular apparatus that is connected via the vestibular nerve to your midbrain and just the central parts. It includes the vestibular nucleus and the brainstem, and then it connects to all these other parts. Most importantly for this talk, the cerebellum, but also the thalamus and your oculomotor centers and the spinal cord. So these are all related. And so when you think of these patients, there are so many different areas that could be affected centrally as well as peripherally. So I had to go way back. I took out my anatomy books and everything just to remind myself of these kind of, what it entails. You don't need to know the details. Just know that there are semicircular canals that depict our rotational motion, and then linear motion by some other parts of it. And these electrical impulses are then transmitted via the vestibular nerve to the brain. All right, so just a little reminder about strokes in general. You have hemorrhagic, so bleeds, and then ischemic, which ischemic strokes make up close to 90% of all strokes. And that can be caused by a thrombosis right at that area, or it can be because there's embolization from a distal source, which is most commonly cardiac. So someone with like a large acute MI might develop a ventricular clot, or if someone has AFib, we know that they're at high risk of blood clots, or if they have valvular disease or something like endocarditis where they might be throwing off some thrombi. And then you also have to worry about arterial embolization, so carotid arteries. That's, I think, what we most commonly think of. And that's going to be the most common site where we worry about the direct extension of the internal carotid with the middle cerebral artery. So that's going to be your anterior circulation. But this talk, we're going to focus more on the posterior circulation. So I like this picture because it clearly just tells you the yellow part over here. That is your vertebrobasilar circulation. And this is what we're referring to when we say posterior circulation. And this is just another picture that depicts the parts of the brain that involves. So it's your brainstem, your cerebellum, which are going to be the areas affected most commonly when you're talking about this imbalance and the vertigo. And then there's a couple other parts of the brain that might be affected. And so there might be some signs on clinical exam that can help you figure out if you have a stroke of the posterior circulation. And I'll go through that in a little bit. But posterior circulation strokes are about 20% of all ischemic strokes, but they're 3 times more likely to be misdiagnosed. So it's a hard diagnosis to make. All right. So in history and physical exam, past medical history, it's similar to anything you're asking patients, the risk factors. If they've had a prior stroke, that is one of the biggest risk factors. 1 in 4 patients that are coming in that are going to be diagnosed with an acute stroke have had a stroke in the past. And then the usual players: hypertension, hyperlipidemia, diabetes, smokers, or if they are obese. So these are the higher risk factors that you want to ask about. I saw this, I liked it. For anyone out there that likes mnemonics, there's 5 Ds of posterior stroke. So if you can't remember anything else when talking to a patient, if you can remember these things, you're going to hit on a lot of the key factors. So you're going to ask about dizziness, about diplopia, or really just any visual changes, about dysarthria, if there's any change in their voice, or dysphagia, if they're having any difficulty swallowing, or dystaxia, meaning is there any sort of irregularity to sitting up, so truncal ataxia, or even gait, standing up and walking. So physical exam, so just starting from the door, the screening test that the nurses are doing is BFAST. It might not be something that you're that familiar with on the floors. I don't know if the nurses there do that in any way, but this is the screening test at triage. And the B and the E of BFAST are balance and eyes. And these are the ones that are going to more closely correlate to the posterior circulation strokes. You also can have some of these motor or sensory weaknesses of the extremities, or changes in speech, but the most common ones are going to be your B and your E. So someone with acute onset of loss of balance, or someone who suddenly has double vision, you really want to start thinking about that. All right. So to go into a test is a great way to approach every patient coming in with dizziness. And so Dr. Edlow has wrote multiple papers on acute onset dizziness and dizziness across the board. And this is what he came up with as a way to approach every single patient that comes in. So you ask about associated symptoms, you ask about the timing and the triggers, specific examination signs, and then testing that you will do to confirm. So the history is, we've mentioned this, but it's onset of symptoms. For stroke codes, anything within 24 hours, that's when we activate the whole stroke team. So if you're thinking about it, it's been within 24 hours, go ahead and get the stroke team involved. If there's other associated neurologic symptoms, the timing and triggers, like I said, and if there's a general medical cause. So we're going to go into each of these just a little bit of detail. So the other neurologic symptoms, do they have focal weakness of their right arm? Do they have numbness of one side of their body? Like we said, changes in speech or vision, or changes, mentation or memory. And then for underlying medical conditions, like I said, about 50% of patients that are presenting with lightheadedness or dizziness have something else medical going on. And you don't necessarily need to go down the route of worrying about a posterior circulation stroke. These can include MI, arrhythmias, a large PE might even cause someone to feel presyncopal. If they have some sort of underlying infection or metabolic derangement, if they're having an upper GI bleed and they're orthostatic, they go to stand up and that's what's causing them to feel lightheaded. If they're dehydrated, or sometimes even if they've started certain medications, anticonvulsants specifically can have toxic effects on the balance centers. So always ask, going through your normal questions first to see if there's an underlying cause. And as far as timing and triggers, this is probably the most important thing so that you can go through the next steps in the algorithm to decide, is this something I need to worry about a stroke or a TIA, or is this something more benign? So are they still dizzy? Has the dizziness, did it start and is still present and it's not going away at all? Or is it continuous, or is it intermittent where there's a specific trigger only when they roll over, only when they move their head? Or is it just gone completely? They had it, now they're here, and no matter what they do, it doesn't come back. So you ask those two questions, and if it is usually a pretty sudden or abrupt onset and the dizziness is persistent, and you might have associated nausea or vomiting, you'll have some nystagmus on exam, they might complain of gait unsteadiness, or anytime they move their head, they just cannot tolerate it. You're going to go down the route of acute vestibular syndrome. So these are the patients that we're worried about stroke. And I'll go into more details in the differential of that in a moment. If it is episodic, meaning it's coming and going, then you go down the route of episodic vestibular syndrome. So this can either be triggered, meaning when they move, it's the only time it's brought on, or it's spontaneous. Nothing triggers it. It came and it went away, and then maybe it did the same again. And usually these just last minutes to hours. The acute vestibular syndrome will come and it can last for days at a time. So for acute vestibular syndrome, this is acute and persistent dizziness. So these patients, the one thing you want to worry about is convince yourself that they are not having a posterior circulation stroke. The other diagnoses that are more benign is vestibular neuritis. And I included a picture here because I couldn't even remember learning about this back in med school. So just as a reminder to everyone, vestibular neuritis is specifically inflammation of the nerve. So you can see there they have the vestibular nerve and it's inflamed for whatever reason. And that can cause this persistent acute dizziness. And that's actually treated differently. You might offer a course of steroids and some like meclizine or something along those lines. Labyrinthitis is not as common, but that's also something that might cause this persistent acute dizziness. And that is inflammation really of the whole apparatus. Other things that are much less common, but you can consider is MS. It's around 2%, I think, of patients with acute persistent dizziness might have the diagnosis of MS, but they should also have some other stuff in their history and physical that you might pick up on. Wernicke's encephalopathy in very rare instances can present as Wernicke's syndrome encephalopathy would also have mental status, but Wernicke's can present with just acute onset dizziness, but it's incredibly rare. And then, like I said, drugs and medication toxicity, you have to think about that. So if the patient is telling you, no, it's coming and going, then you go down the road where you ask them, is it spontaneous or is it triggered? So for the spontaneous, these are the ones you worry about posterior circulation TIA, because as with everything else, you can have TIAs that only affect just the posterior circulation. So you do have to consider that as part of your diagnosis for the patient that had sudden onset dizziness that stuck around maybe for a couple of hours and then it went away. It wasn't triggered by movement, anything else. Keep posterior circulation TIA on your radar. Vestibular migraine, so they might also complain of a headache or a visual aura that associated it, or Meniere's disease, which just as a reminder is caused by excessive endolymph, and they get these attacks that might be associated with hearing loss or tinnitus or fullness, and this can last several hours. And generally it's in middle-aged and older, it's not positional, and these attacks can cause progressive hearing loss over time. So just something to think about as the differential of the spontaneous and episodic. And then you also have to worry about, are they having a cardiac arrhythmia? Are they going into AFib with RVR, and then, spontaneously improving. Other things like that, panic attack, benign things. But these are all diagnoses of exclusion, and also why we do a full evaluation initially with an EKG as well. All right, and then on to the generally more benign, which are your episodic and triggered. So that's your BPPV, which is going to be our most common diagnosis that hopefully we're going to get to. But these patients have benign paroxysmal positional vertigo. So these calcium carbonate crystals get a little lost, and they go into areas that they're not supposed to in the semicircular canals, and it triggers the brain to think that you're moving when you're actually not. So we'll talk a little bit about diagnosing that in treatment in a moment. And then just orthostatic hypotension. When they go from laying down to sitting up, they feel lightheaded. Is that because they're dehydrated? Is it because they're anemic? There's central paroxysmal positional vertigo. I'm not going to go into that in too much detail. I have included some references that talk about it more, but I don't think that's a diagnosis we're going to be making ourselves generally. Also, there's postural tachycardia syndrome, and just something else to think about. I included vertebral artery rotation, which is Bow-Hunter syndrome here, because I just thought it was interesting. There are some people where the vertebral artery courses within the bones there, that when they turn their head, they will cut off blood supply of that artery itself. So that's something that it's a hard diagnosis to make, but if they specifically say it's when I turn my head and then it's a couple of seconds later, it happens and I straighten my head and it's fine, and it's not with change in position up or down or anything like that, it's something to consider. All right. This is exactly what I just went through, going through a test for an acutely dizzy patient. You ask yourself, is there a general medical cause? And then you go through everything else I discussed. Is the dizziness continuous? Is it still there right now? Is it triggerable? And then you go down these pathways and think about your differential diagnosis based on those couple of questions there. All right. I'm just showing this so that you know when the pathway is available on our website, and this is specifically underneath the clinical pathway. It tells you exactly what to look for in a physical exam. So if you can't remember, you can always refer back to it, and it will tell you specifically what to look for. You want to just make sure, because this is also closely intertwined in our midbrain with the nucleus of our different cranial nerves, you want to do a full cranial nerve exam to see if you can pick up on anything small or specific. Nystagmus, and then test of skew, your cerebellar exams, which is your finger to nose and your heel to shin. Truncal ataxia, it's quite simple. You ask, are they able to pull themselves up and hold themselves up in the stretcher without holding on? And then gait, are they able to walk at their, with a normal gait, or at least at their normal baseline with their assistive device? And then there's something called a head impulse test, which I'm not going to go into today because it's really not something that is used by ED practitioners regularly, and is really only studied to be those that are specifically trained in it, like special ENT doctors or neurologists, that if they're able to do it appropriately, they can rule out stroke. But there is a fantastic video I have linked that will show you how to do all of those things in succession. And the more you practice, the more you'll feel comfortable with it. And it will help you just kind of narrow down your diagnoses a bit more as well. I'm including this for reference. It will be, these slides will be linked as well, just if you wanted some more information. But your physical exam is actually your best bet at getting the right diagnosis up front, because I'll talk about imaging in a minute, but it's not 100% the imaging. It actually doesn't have that fantastic of sensitivity, especially in the first 24 to 48 hours. So your physical exam, if you can learn how to do these things, can really help you along the way to figure out what's going on earlier. So for BPPV, there's the Dix-Hall-Pike maneuver. Again, I have a link to a great video that shows you how to do this. Yeah, pretty much that's, if someone does not have any nystagmus at rest and you are not concerned for acute vestibular syndrome, then you're going to go down the route of this, the triggered syndromes, which will include BPPV. And for those patients, those are the ones you're going to do the Dix-Hall-Pike maneuver in. For the patient that you're looking at and they have acute onset persistent dizziness, then you're not going to do the Dix-Hall-Pike, because that's not what you're considering in your differential diagnosis. So it's only for the patients that you think BPPV could be on the differential that you're going to try this maneuver. And then the Epley maneuver can be an extension of the Dix-Hall pike if it's a positive test, and that's a way to treat the patient. And the Epley maneuver for true BPPV is effective about 80% of the time, and you can repeat it if it doesn't work the first time. Okay, so moving on to testing, which is talking about imaging pretty much. So for imaging for these patients, non-contrast CT head, if someone has had symptoms for quite some time, they're also complaining of headache, or they have any altered mental status, a CT head could be really beneficial because it might show you if they have an intracranial hemorrhage, or it might show you that they've got a stroke in the cerebellum that has edema and you're worried about herniation. So that is really the reason to do CT head in these patients. It's fast, it's readily available, but it's not very sensitive. And I'll give you those numbers in a moment. The MRI is going to be a lot more sensitive, but it's also slow. It's resource intensive, and some patients can't get MRIs because of specific devices they might have in their body. The sensitivity for CT head non-con for all strokes is about 7 to 16%, depending on the study, and it's even less for posterior fossa. So it's really not a good test. But if you're concerned about a patient and you really just need to know, are they, do they have edema? Are they going to herniate? Is this a large bleed? Then it's a test that you should get right up front. And just a caveat, and I thought this was interesting to include, that there was a large study in Canada of ED patients who were seen in the ER, diagnosed with some sort of benign dizzy diagnosis like BPPV or maybe vestibular neuritis, that came back and had a stroke when they returned. They actually had a CAT scan 2.3 times more often on their first visit. So the physicians or whoever is seeing the patient correctly identified patients that they were worried about a stroke, but they didn't do the right test. So I just thought that was interesting to note. So for MRI, which is the MRI diffusion weighted imaging, is specifically what they're talking about, which is I think what we're doing for all of our patients. But even up to 48 hours after symptom onset, they can be falsely negative for posterior circulation strokes in like 12 to 18%. And I hate that fact. It's a horrible number. So just something to think about. These patients that have persistent symptoms, especially if they have neurologic findings, if the MRI is done in that 48-hour period since it started, it's definitely worthwhile considering maybe repeating it if those symptoms continue to persist, because that first negative MRI might not have picked it up. Maybe it needed more time or something along those lines. And definitely neurology or the stroke service should be on board for all of these patients, which is actually part of the new clinical pathway. We will be working with them more closely for posterior circulation strokes. And also just something for posterior circulation strokes, if it's a smaller stroke, which is defined as less than a centimeter, it's falsely negative in about half of the patients. So it's really just not good in general for those patients, but it's the best test that we have outside of our physical exam. All right, so vascular imaging, specifically, you're looking at the intra and extracranial vasculature, and you're looking for specific stenosis or an area of occlusion or dissection. So carotid or vertebral artery dissection is also a possible cause of a posterior circulation stroke. So this is just the general sensitivity and specificity. Both CTA and MRA are quite sensitive, so they're both good tests. CTA is obviously faster and less resource intensive, but the downfalls would be that some patients can't get IV contrast, so you won't be able to get that test for them. And MRA, if you do an MRA head and neck along with your MRI brain, it's adding an hour to an hour and a half on the MRI table. And we only have one MRI machine at each hospital. So just something to think about, with these patients, that if you can do the CTA, it's better just from a resource standpoint. And actually, it's even a more sensitive and specific test. And you can do carotid ultrasound if both CTA or MRA are contraindicated, but just noting that it is a little bit less sensitive and specific. All right, so just to kind of bundle it all together, our general TIA and stroke workup, you're going to look for an acute stroke with your imaging of the brain, CT head and or MRI brain. You're going to check for arrhythmia. So you'll do the EKG, you'll keep them on telemetry, see if they're having any paroxysmal AFib or anything of the sort. You're looking for this atherosclerosis or dissection, any sort of narrowing of the vasculature with the imaging I just discussed. And you're thinking about other, cardioembolic causes on physical exam. Do they have a murmur? Do they have signs of CHF? Do they have any evidence of infection? Do I need to look for endocarditis? And you can consider echocardiogram with bubble study in these patients. All right. So I'm not going to go into detail about this, just noting that the reason for telemetry monitoring for the patients with TIA and stroke is about 20 to 25% of TIA are from AFib. 2% of those are new diagnosis when they present with that TIA. But noting just if a patient has a normal EKG, no cardiac history, no really clinically evident cardiac symptoms, then less than 3% of these patients are found to have any significant abnormalities on echoes. So that's a whole discussion as to really, is it worth keeping the patient in the hospital for an echocardiogram for the lower risk TIA patients? But that's a little outside the scope of this lecture, but just something to keep in mind. The ones that there is agreement that definitely should have an echo is someone that you, for any reason, are worried that they could have some sort of cardiac thrombus, or they have a new murmur, they have new AFib. So these are the patients that you're considering doing an echo and maybe even a TEE alongside discussion with the neurology team. And sometimes someone has just like a classic perfect story for a TIA, and this is definitely what you think they have, and you're worried that they have a PFO, then you can do the echo with bubble study. All right. So, we kind of went over everything. If whatever's not done in the ED, what happens in RE2 or when they're admitted? If the MRI wasn't done, then that's generally completed, depending on if that's still believed to be the most likely diagnosis. If the vessel imaging wasn't done, then we will complete it. Then you can consider your echo with bubble study for the select patients that it might benefit. And then you can continue them on telemetry. And for those patients that you're worried are having some sort of an arrhythmia that you didn't capture while they were being observed, maybe they were in the ED, not on true telemetry or something of the sort, you can consider referring them for an event monitor or Holter monitor. All right. So I went over this in the TIA lecture. I'm going to kind of breeze through it quickly because we're going to run out of time. But so you found something on the imaging. What are you going to do? So if you found an acute stroke or a bleed, you call stroke and or neurosurgery. Vertebral artery dissection is something you have to think about. This is often one of the patients that are missed because it might be in a younger patient with an atypical presentation. So always think about it and think of it as one of the reasons why we do this vascular imaging. And for those, you're going to get your stroke team on board and maybe vascular. If you find a PFO, you definitely should refer for transcatheter closure because there have been studies that showed a significant benefit over medical therapy in preventing future strokes. You're going to treat any underlying cause you might have found. And then let's just go back to the case that we talked about. So the gentleman, the first case with the multiple medical comorbidities, think about what would you ask him? What would you look for in physical exam? And let's go through the attest algorithm that I proposed. So associated symptoms, you asked him and he's like, yeah, I have had difficulty walking. I have fallen a couple of times in the past 2 days and I've been really nauseous and vomiting. And so you ask, is it constant? Is it coming and going? It's constant. It's been there for the past 2 days and I still have it right now. It is worse when I do try to move around. And the reason I've included this fact is just because someone says it's worse when they move doesn't mean it's peripheral, because all of these types likely will be exacerbated by movement. But the difference is it completely gone in between with rest, or is it worsened by movement? So, and then on exams, you are going to examine the patient and you see that they have this unsteady gait. They're walking with their rod. Sorry. Okay. Just want to mute. And that he's past pointing on his finger to nose on the left-hand side. So this patient, this is a true case. This is actually one of the cases that made us decide that we were going to work on an acute onset dizziness pathway and education, because this was a patient that had a delayed diagnosis of a posterior circulation stroke. The initial CT head confirmed his chronic infarcts, didn't show anything acute. And when the MRI was completed, it did show that he had recent infarcts in the medulla and the left posterior cerebellum. So, and just another reminder that the CAT scan is not a good test for these patients. So the discussion point, the patient has a prior stroke, multiple risk factors. This is definitely someone that I'm going to keep and complete the workup, either in observation or in the hospital, depending on if they have persistent deficits. This patient, when they were initially seen in the emergency room, did not have a full neuro exam completed or documented. So it really wasn't even on their differential diagnosis. It was a great catch by the person that was working in the obs unit that day. And it's just for these patients with persistent, constant dizziness, always consider stroke as a potential etiology and consider imaging and getting neuro on board. The second case is our gentleman with hypertension who has this dizziness that's gone when he's resting and only comes on when he moves his head in different ways. So you ask about associated symptoms. He's also nauseous and vomiting. He can walk. He feels a little unsteady just because he's so dizzy. But once he stands in place, that dizziness goes away after about 30 seconds. It's only when he turns his head, no dizziness after resting. And on exam, you decide to do the Dix-Hallpike because this is a triggered and episodic event. And he does have inducible nystagmus, no nystagmus when he's just sitting up at rest. And you do a full cranial nerve exam, finger to nose, gait, all of that is normal. So he doesn't need any imaging. You do the Epley maneuver and he has complete resolution of his symptoms, as 80% do in the emergency department. So again, this is the pathway. It's going to be on our website for reference, and I will let everyone know when it's officially rolled out. It's important to know about on the inpatient side, but it will more closely affect the observation unit and patients that end up there, but it doesn't change anything with the exclusion criteria. Patients with persistent physical exam deficits need to be admitted either to neurology or medicine because it's presumed they have a stroke. All right. I have 3 minutes left. I'm sorry I had to rush through that a little bit. Are there any specific questions, anything that you want me to clarify that I can send out to the group? Anything?